Chairman, dear audience, which is left, I welcome you all to Savonlinna, to Finland, to Lake District. We have here 600 years Olof's Castle, and inside the castle there is every summer, every July, a big opera happening. I'm plastic surgeon, and in breast reconstruction I use mostly patients' own tissue. Even within patients, those implants and expanders are in use. And my first free flap reconstruction I performed 1991. And I found that the skin sensibility of the reconstructed breast was very poor, and that's why I started to seek nerves for neurography. And in year 2001, I performed my first microneurovascular breast reconstruction. And this, does this work? Oh. This transversal muscle abdominis TRAM flap is very soft and natural tissue and gives a good consistency and shape for a breast. I chose this procedure rectus muscle sparing type instead of perforant flap, so-called DIEP flap, because nerves follow the perforants, vascular perforants, and I feel that it's better to spare so many nerve branches to the flap as possible. 3 lowest thoracal intercostal nerves gives the sensibility for the lower abdominal skin, and it is possible to find nerves from both sides of the flap. This lady has total normal sensibility of her reconstructed left breast, but sometimes the skin color of the lower abdomen is a little lighter, and those mastectomy wounds will be visible. This, I have drawn this tissue skin flap, which I take, and then the fat tissue underneath, and this forms the breast. And this mastectomy area, the nerves have suffered from breast cancer treatment, mastectomy, radiation, and axillary evacuation, but there is always possible to find medially thoracic intercostal nerve branches subcutaneously or underneath the ribs. And axillary area, there are certain nerves for nerve anastomosing. And this was the delayed procedure, the further one, and it is possible to make in immediate breast reconstruction skin sparing mastectomy, and I have taken all glandular tissue with nipple away and then form it back with this transversal muscle sparing TRAM flap. And this skin along islands, they lose their sensibility somewhat, but in this case the aesthetic result is best available. And I try to formulate the breast with a normal one so that they will be equal. Sometimes with ptotic breast it's not possible, then I need to correct the healthy one too. And first I started to find nerves in the side of the vessel pedicle, And here I have dissected two lowest intercostal nerves, number 12 and 11, and vascular pedicle goes underneath. But later on, I wanted to get better results, so I continued to take bilaterally nerve anastomosis, and this is the opposite side of the vessel pedicle. Through small opening in the fascia, it is possible to dissect the nerve for later anastomosis. Yap et al. Has shown in their cadaver dissections how this nerve net is formed in lower abdominal skin, and it makes it possible, this neural net, that even with one nerve, unilateral anastomosis, it's possible to get normal sensibility for this flap. And here are the standard nerves in axillary area, which are always available. This intercostobrachial nerves, which give sensation for brachy, and then nervus intercostalis, which goes always at the bottom of the fossa axillaris. And in case the surgery has damaged them, then there will be nervus thoracoldorsalis, which goes to the latissimus dorsi muscle. At least that is available. And the anastomosis is possible to make for a free branch with end-to-end anastomosis. But in case there is no free branch of the nerve, I used to put the nerve anastomosis end to side to the nerve stem, because I don't want to cut any healthy nerve from this area, because already the sensibility has decreased. And this is in practice. All this sensibility recover was testing in a big quantitative sensory battery, and it was made before operation and after 1 and 2 years operation. And skin biopsies were taken for microscopic analysis for nerve regeneration, and somatosensory evoked potential for a more objective specimen, and patient questionnaire was made. The used zones for sensory testing are seen here. The mastectomy area was for quarters, and on the right side there is in reconstructed breast and the healthy breast on the other side, and in abdominal skin. Total sensory scores was counted, and it was the sum of individual scores of different tests. And highest and lowest recorded value of the normal sensing test defined the limit of scores. And the results. First, we performed unilateral nerve anastomosis on the side of the vessel pedicle as a pilot work, and it showed up that we could achieve a double better sensibility with neural anastomosis comparing no neuro anastomosis. And then secondly, we found out that it did not decrease the sensibility of the abdominal skin. There is always low underneath the umbilicus, small area with lower sensibility, but unilateral or bilateral nerve anastomosis did not make it worse than with no neuro anastomosis either. Here, the left side, the nipple reconstruction is made, but tatuation, areola tatuation is coming later. And at the moment, 96 free flap breast reconstruction have been participated the study, and 76 of them have been neurovascular TRAM flaps. And most of them, if you look this total column there, most of them have got axillary evacuation and radiation, and half of them have got chemotherapy. And one-fourth of them I made as an immediate reconstruction procedure, and three-fourths as a delayed breast reconstruction. My operation time was on average 7.5 hours, and flap ischemia time was about 1 hour. The size of the breast was on average 600 grams, and follow-up time was over 2 years. And this total sensibility scores, which is in red line at lower part, you can see on the right side the healthy breasts. This sensibility scores is a little under 30, and this neuro group I could achieve half of the sensibility from the healthy person in median, but there were some people some breasts who had totally normal sensibility, and some, of course, who did not have so good result. And comparing this neuro group to no neuro group, it was clear, significant difference, so that the sensibility return was much better in neuro group. At the moment, I have prepared my study between bilateral and unilateral neurography groups, but it is coming to publication soon, so you will hear about if you want to read later. It has been a great privilege for me to have an opportunity to share this study with you. So I thank you all very much.
Thank you very much, Helena. The last speaker would be Dr. Hensler.